And then let's admit people to the room. Fantastic. That's looking good. Let's cancel the audio so there's no feedback. Great. Well, let's just wait 1 minute so we are not starting too early. And then so excited about this talk. I've been looking forward, like this was in the making for like a year.
Okay. Well, I hope you're not disappointed by the end of it.
Sure won't be.
Okay.
Such a privilege to get like actual clinical insight. So thank you both for being here. Absolutely fantastic to have you. Okay, let me just mute people. Voila. And I'm just going to make you co-hosts as well.
Hello.
Hello.
Hello. I'm joining from Switzerland.
Oh, fantastic.
I saw the topic is very interesting. So thank you for giving us the possibility to follow this seminar. Thank you.
Thank you so much for joining us. We're quite international today, I think. So we have France, the UK, Switzerland, maybe even more. I don't know, the others are incognito. Great. So you're all co-hosts now. And it is 4 o'clock. So let's start. Thank you all for being here. This is our last CNS talk for this year. For those of you who are keen to know what's coming next, check the website. It's updated with all the talks for next year, and we're nearly fully booked for 2021, so that's going to be exciting. Well, today we have a double bill. So we have 2 speakers, both clinicians, and they will give us their insight in COVID and the brain and how their clinical routine looked like over the last nearly 2 years now. So the first speaker for today will be Harith Akram. He is a consultant neurosurgeon at the National Hospital for Neurosurgery and Neurology in London, and also an associate professor at the UCL Institute of Neurology. And then our second speaker is Hamid Merdji, who is a who's a medic at the intensive care unit at the University Hospital in Strasbourg, and has co-authored quite a few papers on the subject recently, including the neurological features in severe SARS-CoV-2 infections in the New England Journal of Medicine last year. Now, without further ado, Harith, if you want to take it away.
Okay. Thank you, Stephanie. Thank you very much for this introduction and for inviting me to talk today. Let me just share my screen. Okay, yes. So I'm a consultant neurosurgeon at the National Hospital of Neurology and Neurosurgery. It's one of the biggest neurology and neurosurgery centres in the UK. It's one of the biggest in the world. And we're part of University College London Hospitals. We're also we're part of University College London as well. So we work together. And in fact, my office is at the UCL Institute of Neurology. And I'm not going to talk a lot about the technicalities of COVID-19, but it's more about personal experience and what we've been through and what we learned from it, and we're still going through. Right. So neurosurgery it's a very highly subspecialized area. So we do quite a lot of things including here you see on the left, this is a patient with an acute subdural hematoma, so intracranial hematoma from trauma. We do tumor surgery, hydrocephalus, the scan in the middle, vascular surgery, spinal trauma, and all of these areas are quite acute, and most of the times we're trying to prevent death or permanent disability in these patients. which means it's very time critical. So we can't really not do these operations. Now, I do some spinal surgery and kind of general neurosurgery, but also my other super specialty is functional neurosurgery. And if you follow me, you'll see why I'm trying to make this distinction. So functional neurosurgery is not acute. This is not an emergency operation. What we do is we make surgical intervention to improve the quality of life and improve function that is lost. So, for example, our bread and butter is in movement disorders. So we treat patients with dystonia, Parkinson's disease, essential tremor, and these are patients with quite debilitating symptoms that need, they've failed medical therapies and now they need something else. We also treat a lot of pain conditions. So, for example, this is cluster headache, trigeminal autonomic cephalalgia. It's one of the worst pains known to man. Or trigeminal neuralgia, which is another type of facial pain. We treat patients with cancer pain. So we do operations, palliative operations, to disconnect the perception part of the brain, so where you get your sensory input, and disconnect that from the emotional part of the brain. So you can still, for example, patients will still feel pain, but they won't feel the suffering, and this way it helps with suffering. We also do surgery for mental disorders, so patients with Tourette's, for OCD, with depression. All of these things are elective. These patients are really suffering, they're really struggling, they're waiting to have surgery, but we can't justify operating on these patients when there's a pandemic, which is why a lot of this stopped during the pandemic. Now, I show this slide. I quite like this article in The Guardian, and this is written by an anonymous anaesthetist. And it's an ongoing thing between anaesthetists and surgeons. And this is about who's more important and whatnot. And I don't subscribe to any of this. I think we all work together in a team. We can't do surgery without them. And they there's no point in them putting patients to sleep if we're not around. But I'm putting this here to show that even if we're around, if the anaesthetists aren't available, we still can't operate on patients. We can't do our jobs. Incidentally, this man here is Walter Dandy. He's was a famous neurosurgeon in America. He's credited for creating the first intensive care unit. And it's because neurosurgery patients often require a high level of care following surgery for most of the operations, which is why we're also dependent on availability on ICU and HDU wards. So without those, we can't do our jobs. Now, what happened during the pandemic is that our big hospital, the big trust, because we're a centre, we're one of the biggest hospitals in London, we became a major COVID centre. And that meant that we were getting COVID patients from all over London and from outside London as well. And we partnered up with the Francis Crick Institute, which is an academic institute very close by, and they turned all of their labs into COVID testing facilities. So they were doing the research on the virus. At the same time, they were doing all the COVID tests for us. Now, what did this mean? This meant that we had to stop all elective surgery. And this came from NHS England. So we weren't doing any elective surgery, only doing emergency operations. Our staff were retrained and redeployed. So that's most of our junior staff had to then go to the main hospital, the tower, to work on ITU or HDU. Our operating theatres were turned into makeshift HDU and ICU beds, and that's because they're already equipped with ventilators. So it's very easy to put a patient there. There is a ventilator, and then you can look after them there. Our anaesthetists were very much in need everywhere. So they they weren't able to cover non-emergency operations. And we, as neurosurgeons, so we were giving the choice. We could stop doing elective surgery, focus on emergencies and not do anything else, or we could actually try to actively engage in the process and kind of play a role in the pandemic. So we decided to go on a shift rota. So normally we don't do that. We're on call and for a weekend or for 24 hours. But we went on a shift rota, and we started covering different areas in the hospital. So a neurosurgeon will cover emergencies, another neurosurgeon will cover spinal emergencies, one will go to ICU to help with ICU, or actually more than one. And we were covering lots of different areas in the hospital. Now, luckily, 6 months earlier, our trust went completely digital. So they got this new system called Epic, and we were ready to do remote medicine. So we could access notes, we could do virtual clinics. And now serendipity played a major role in this, because actually, before the pandemic, we were all complaining that we now have to do everything on a computer screen. But it worked out really well because we were ready and we could do that. So a lot of clinics continued either using video clinics or telephone clinics, and we can pull patients' data and scans and write them letters and all of that. So that part didn't stop. Now, we were deployed to ICU because our main ICU at the National Hospital, the neurosurgery, was full of COVID patients. These are non-neurosurgery patients, but they're patients that the main hospital would send to our ITU because it's one of the big ITU wards in the trust. And we all worked on ITU. We were proning patients, and I'm sure you've heard of what that means. We know that patients who have a lot of respiratory complications can be helped by just moving them on their tummies and then moving them back on their backs and kind of rotating that in shifts. And that's quite difficult to do with patients who are intubated and ventilated. So, these patients have tens of lines going in and out. They have a tube going down, and it's, if it's not executed properly, they can die. So that was something that needed a lot of people to help with, and it's very physical. And that's what we were doing on ITU. We were changing, I personally was changing bed sheets. We had neurosurgeons calling family members to update them every day because we didn't want the ITU doctors to not look after patients and be on the phone all the time. So we were doing all of that, and that was actually quite hard, especially if we had to tell them bad news. I did shifts at UCH, so the other side, the main side, where I was just sitting outside ITU, making sure that they have PPE, making sure that the bins are emptied. I would get things in and out of ITU because they can't leave every time they need something. They have to call for it because obviously contamination issues and PPE changing issues. And that actually really brought it home for us, because you'd be surprised, we don't actually see death that face to face that often. And a lot of our patients unfortunately die because of the nature of their diseases, but we don't see that. It's all very sanitized. Patients often kind of go to ITU and then they go to palliative care when they reach the end of life. But this was raw. We were seeing patients dying, every day. We see patients that we were looking after, they go in and out. And because we're there to help, we're the ones who are, for example, I was, getting body bags for the nurses on ITU. I've never seen one before in my life because it's not something I get involved with. I was putting PPE on a patient, his son who was 6. I had to put PPE on him to go and say goodbye to his dad, and that really brought it home. That was very, very difficult. And I was just there as a volunteer. I mean, Hamid will tell you about what he's been through, because I have great respect for IT doctors and nurses. They've done an amazing job. Now we started to open up a little bit in terms of surgery, and we started operating on patients. All the patients who had, for example, weren't emergency operations, but they were struggling a lot. For example, patients with pain and patients who, if we didn't operate on, they would become emergencies. And at that stage, this big international cohort study was published, and from the COVID surge group, and it found that actually, if you operate on someone within 30 days of COVID or being diagnosed with COVID, in the perioperative period, they have a 24% increased risk of mortality. So this is not mortality risk, but an increased risk of mortality from if they didn't have COVID. And that was, although it's rare, because we test patients quite significantly and make sure that they're isolated, and it's still quite a big increase in mortality. And that meant that we had to do something to isolate elective patients from all other patients. Now, this is what our hospital did. We devised 2 pathways. One pathway called the green pathway, for patients who have no comorbidities, who have no, for example, they're not at high risk if they got COVID, but also no history of exposure, negative test, they were self-isolating, and a blue pathway for patients who we're not sure if they've been exposed or they've come as an emergency admission. So obviously we don't have time to do all of these things. And patients who are COVID positive, they would be isolated, but they would still be within the blue pathway. Now, what that meant was we had to basically have 2 of everything. So we had to have lifts for blue patients, lifts for green patients. We had to have a high dependency unit for blue, high dependency unit for green. We had to have recovery ward for blue, recovery ward for green. And you see what I mean. Even entrance to the hospital, we had to have a green and a blue entrance. And we can't mix the 2 because that goes against the whole premise. That means that we can, the facilities we can separate, but it also meant that the staff to man both. So rather than just needing 1 recovery team, we now need 2 recovery teams. Instead of needing 1 anaesthetist to do a list, we now need 2 anaesthetists, and we can't share between the 2 teams. And that put very, very big or high pressure on the service, and it meant that the capacity of us to do any work was further reduced, even though we're now just trying to catch up, trying to get back to doing our jobs. Now I'm going to talk to you about other COVID-related complications that are directly related to what we do or had an impact on what we do. So this is not new. It's known that viral infections can increase the risk of stroke for many reasons. But we started to see young patients with stroke. We started seeing a lot of young patients with stroke, and there were patients who would come to us and they're treated and they go home and then they have a stroke, and that was very odd. And then the study came out in the Lancet, and it found that actually, if you have a COVID infection, and you're at 7.6-fold increase risk of developing a stroke than if you've just had an influenza. So there was clearly a much higher risk of getting a stroke with COVID. It's still very rare, because obviously the risk of getting a stroke with influenza is rare, but this is higher. And that's why we started to see, and because of the numbers of patients, it was becoming apparent. Now, we don't know why it happens. There are different theories. It could be that it's because of the cytokine storm. You get, your body's response to kind of systemic inflammation is by making your blood thicker. You get a hypercoagulable state because, this is what happens in trauma. You don't want to bleed out, so your body's ready to. So that increases the risk of thrombosis, or blood clotting, causing a stroke. It could be an immune-mediated response that's triggering the clotting process, or it could be a direct injury to the blood vessel lining, or inflammation of the blood vessel lining that would lead to the blood vessels kind of clogging up and causing a stroke. And what was worrying is that we started to find viral particles in different tissue types, including brain tissue. Now, this is just another study that found something similar, not in patients with COVID, but in patients who've had the vaccine. And that also, so we started to see patients with something called venous sinus thrombosis. And that's the brain has a lot of blood vessels going into it and major veins. So the veins carry the blood from the brain back to the heart to kind of keep the circulation going. And if these veins get thrombosed, so if these veins are clogged up, the blood can't go anywhere. So the pressure inside the brain starts to get higher because there's still blood coming from the heart, but it's not leaving the brain. And that means that you can present with things like a hemorrhage on the brain because the blood, bursts through and you get a hemorrhage. Sometimes it's not a hemorrhage, but you get hydrocephalus, so you get increased building up of fluid in the brain, because that fluid also needs to circulate and it goes through the veins. And if the vein is plugged up, it can't absorb the fluid in the brain, the CSF, and you start to get building up. And both conditions, you have increased pressure inside the head. It's called the intracranial pressure. Now, both these conditions are neurosurgical emergencies. So we had to go to work. And what we do in, for example, this is on the left, we do something called a hemicraniectomy. So we remove a big portion of the skull, and that's to allow the brain to expand, because the skull is a closed cell. There's no space for the brain to swell after a stroke. When you have a stroke, your brain starts to get angry and starts to swell. If it continues to do so, the pressure will start to get even higher because there's no place for it to go. And when the pressure gets higher, the blood supply coming from the heart can't get into the brain because the pressure inside the brain is higher than, or the pressure inside the head is higher than the pressure that the heart is pumping at, which is your normal blood pressure. And then there's something called the cerebral perfusion pressure, which is the differential between the two, the pressure inside the head and the pressure inside the brain, becomes too high, and then the blood stops getting into the heart. You get more stroke, and then you get more swelling. So we need to do something early on to stop that from happening. What we do is we remove a big part of the skull as an emergency, and then we allow the brain to expand. And then when the swelling goes down, we can then replace the skull by doing another operation, and we use a plate, usually a synthetic plate. On the right, this is just to show you what it's like. Now, I don't do an incision like this. This is also for trauma. It's not for stroke. But just to give you an idea of the size of the opening. And here on the right, figure C, you can see a blood clot. So this is an operation for a brain injury. But just to give you an idea of what we do. Now, another worrying development was that in autopsy cases, here on the bottom left, we could find SARS-CoV-2 in brain tissue. Now that's quite worrying. And other signs of the virus getting into the brain are, for example, the anosmia, loss of sense of smell, or loss of taste. And when that happens, and we know actually from previous studies of other SARS viruses that the virus can make it into the brain. We know from rodent studies that that happens. And this is quite worrying because what happened after the Spanish flu, a few years after the Spanish flu, the incidence of Parkinson's disease in the community went up by threefold. And that's, we think, is related to the influenza virus. Now, we don't know if this is the case with coronavirus. It's still too soon, still too early to tell. But this is something we need to keep an eye on. We know that coronavirus, and I didn't talk about this because it's neurological rather than neurosurgical, but we know it can cause different types of inflammation in the brain, something called encephalitis or encephalopathy. So so this might be, the consequences of this might be with us for a long time, but we don't know. Now, where are you now? So we've had a very good vaccination campaign, but the pandemic isn't over. And you can see here that the number of cases started to go up again in August, and the number of cases are still high. Not as high as the last peak in January, but this is not getting translated into hospitalization. That's reassuring to a degree. Also, the number of deaths are still, didn't go up as they did in January. Now, the problem is, and I don't know how much you know about the NHS, but we have a crisis every winter because of, the flu season, and because of lots of issues that I'll talk about in a bit. But because we were isolating and wearing masks and everything last year, nobody got the flu last year. Now, what tends to happen is if you don't get the flu one year, you get it with a vengeance the year after, because you didn't, there's partial immunity building up every year. You get, there's some cross immunity. And if this year ends up being a bad year for flu, then we might really struggle, because the beds are occupied by hospitalized patients. They're not dying, but they're hospitalized. And if ambulance services can't offload patients to hospital wards, to emergency departments, and there'll be a backlog of these patients, and then the ambulance service will stop working, so they can't go and pick up new emergencies, and you can follow where this would lead. So we get the winter pressures every winter. This year, we have the added pressure from coronavirus cases. Another problem that we have in general in England is that the waiting lists are now very high. So for knee replacement surgery and hip replacement surgery, I think that's 4 or 5 years, patient having to wait to have these operations. I know, speaking personally, my waiting list is into next year, and it's very difficult because we had to cut down on kind of operating time because of all the things that I mentioned earlier, the green pathway, the blue pathway, and the fact that the anaesthetists are busy. But also we have an acute shortage of staff. That this used to be chronic, now it's acute, and that's part to do with a lot of people leaving the NHS because of staff burnout, but also because of Brexit. We've lost some of the best nurses and doctors that we had, and other staff that used to keep the NHS going, but that's been a big problem. And we have equipment shortage. That tends to be a daily thing. Some of it is to do with supply chains. That's an international issue, and that's also affecting the way that we can get our work done. Now, it's not all been bad. I didn't want to finish on that bad note. I want to show you something positive. Actually, we learn to work more efficiently now using technology, and it's not for everybody, but we can triage. So I can if I know that an elderly patient just needs reassurance or needs to hear the results of the scan, then I don't need to drag them all the way to a hospital, get them to go through public transport, and I can just have a video consultation or a telephone consultation, and I can give them the results or check on how they're doing, and that was a positive. That's something that was I think it was going to happen anyway, but the pandemic was a catalyst for it to happen because we really needed to get this done. During the time when we worked in a shift system, we really developed a sense of common identity. We're working as a team, working together. You go to a handover meeting in the morning and you see 6 or 7 neurosurgery consultants together discussing plans, and it's not an MDT meeting. It's just this was every day, and it's not just us. Us working with the anaesthetists and the critical care doctors. We developed this sense of common identity, and we felt that we were doing something to help the pandemic, with the pandemic and these patients. And also, a lot of us actually learned to appreciate the time that we spend with our family and with friends. The time that we spend outside work, that became very, very precious. And it made us reassess what is important and how precious this time is, and how we should really spend it doing things that we enjoy with the people we love. So I'll leave you with this. For example, my son, Frankie, he loves gardening, and we planted lots of trees. This is a lemon tree that we planted. He also loves baking, so we do a lot of baking together, and you can see that it's not bad, considering I've had time to practice. It is what it is, and I think it will pass. We'll get over it, but until then, we just have to keep working hard. And that's it. That's what I wanted to finish with. Thank you for listening. I'll stop sharing now.
Yeah, thank you, Harith. It was really, really interesting, and thank you for your work. I imagine that it was not easy as you described, but there are also positive things too, and it's a good ending, I think. If everyone, I think we can have time for a few questions now, and then we can do like a wider discussion later on. If someone of you has a question, please feel free to raise your hand. Okay, Valentina, go, or write it in the chat box. And okay, Valentina first, then Stephanie. You have 2 questions already. Go.
Thank you, Leah. Thank you, Harith, for your presentation. My question was on the data that you showed on COVID and stroke, the relationship between COVID and stroke. And I was wondering, did you find any relationship between patients' comorbidity and the occurrence, the probability of stroke, or patient genetical predisposition to stroke and the probability of having a stroke after COVID? Thank you.
Yes, that's a very, very important question. Thank you, Valentina. You asked me if I found. It's not my work, so I can't. It's not me. But what was found was younger patients were getting stroke. Also, male patients of certain ethnic groups. So there were kind of ethnic minorities, so Black and Asians in the UK. Now we mustn't forget that about 1% to, depending on where you are in the world, to 6% of patients with COVID also have their vascular paths, so that they have pre-existing blood vessel disease, so they're also predisposed. So that's one factor. Another complicating factor is actually there's something called quarantine effects, or lockdown effect, because you're not going out and you're getting stressed and all of these things, and lots of people were getting healthier, doing exercise. that reduces the rate of stroke kind of on average. So it's not straightforward. There was mostly stroke that was found in ethnic minority groups, patients who are male, and patients and there were lots of different patterns. I mean, when I was on ITU, this is not evidence-based, but you can see most patients on ITU, for example, with COVID, and this is during the first pandemic, so the pattern did change. But there were patients who were overweight men, in their 50s, 60s, who were bald for some reason. Whether that has anything to do with it or not, I don't know. That was just an observation. But we're continuing to learn about the disease, and we don't know why some patients are more predisposed to complications with COVID, whilst others don't show any signs or symptoms from it.
Great. Stephanie, do you have a question?
Sure, I'll try to be brief. Thank you so much, Harith. That was a wonderful insight into your daily work, and thank you for sharing that with us. You mentioned that looking ahead into the winter month now, that there might be a worry that with a new flu cohort coming in, the hospital beds are already filled up with COVID patients. And I was wondering if you had numbers on the average duration of a COVID patient in hospital.
I don't, I'm afraid, I have to say, but I think the fact that this is a good thing, that patients aren't dying, and there's no, there's no quick turnover time, that I suspect patients are staying in hospital for longer. The ones that end up in hospital tend to stay in hospital for longer. But we've learned a lot, though. We've learned about the role of dexamethasone in these patients, anticoagulation in these patients, hemofiltration, all of these things. And I don't want to step on Hamid's toes, because I'm sure that's his territory. And in fact, he should probably answer that question later. But I don't have statistics, I'm afraid. I don't know. It's quite difficult to get these numbers as well and be accurate.
Yes, maybe we can also come back to this question also later in the wider discussion. Lauren, you have a question? Last question? Can you hear me?
Yeah. Can you hear me?
Yes.
Oh, fantastic. Hi, thank you so much. Hi, how you doing? Thank you so much. It was really insightful to hear, and sort of interesting to hear your experience with what had happened and what was going on for such a long time. And I think, as someone who's not necessarily, I don't work at all in hospitals or with patients at all, it's sort of interesting to see, because we always think doctors have sort of they're used to dealing with death, let's say. And I think it's sort of not necessarily, we just have that stereotype where we think doctors, they always deal with death. It's always an option. And so we don't think necessarily that, we think you're sort of prone, like it's sort of, you're used to it and you're prone to having deal with that sort of question. So I'm wondering, actually, looking at sort of, over the last year or two, what you've sort of seen directly, has that had any impact on, I guess there's two questions to this. Did you have any sort of post-traumatic stress, I guess, from seeing and dealing with death constantly? And has that impacted how you work today? Because obviously maybe that changed how you kind of view what you do every day in terms of in doing surgery.
Yeah, they're very good questions. Thank you, Lauren. I mean, I always think I have good mental resilience. And you have to if you work in neurosurgery and you do what we do. I guess the difference between the pandemic and our normal exposure to death is, well, a few differences. One, this is affecting patients who they were basically who were dying. They were okay 2 or 3 weeks earlier, right? So they didn't have a chronic illness, most of them, but this is before vaccination. So some of them are young patients with young families, and the numbers were very high. And also the fact that caring for these patients is very physical. So, you know, we're touching these people every day, right? We, on ITU, they're getting cleaned every day and looked after every day. So there is that, even though they're intubated, there's that direct human contact with these patients who, you know, they didn't have cancer. They weren't dying for a while. It just happened very quickly. And the numbers, that was a very difficult thing. And the fact that when someone died, it wasn't like, and again, Hamid probably knows about this more than me, but we didn't stop. We just had to get, you know, there was a bed now empty on ITU so that you get the next patient straight away. There was no time to grieve, you know, you just have to get on with it. You know, I broke down a few times. And again, I say this and I'm embarrassed because I didn't really do that much for it was the ITU nurses and the anesthetists and critical care doctors. But, you know, doctors are human too at the end of the day. And there was actually something in the news this morning about a lot of patients, NHS staff who've been referred to psychologists and have been diagnosed with PTSD. Now, I don't like using that term because, you know, we didn't die, our relatives didn't die, and I think it's, you know, a lot of people are going through, you know, much worse circumstances. But I'm sure it scarred a lot of people, especially those on the front line. And it would be, there's no way that this has not changed the way we look at death and we treat our patients. And I hope it just made us all kinder, not just doctors and nurses, but everybody kinder towards each other.
Wow, thank you. That was really touchful from my side because I imagine how hard it should be, and the scary thing that we think it's not over, and so we are trained, but it's also, I think, difficult to maintain the stress for a long time. It's not just one surgery, one moment. It's really hard to sustain this also in the hospital. Yes, thank you for sharing your experience.
My pleasure. Sorry, I overrun. Right,
no, I think we are okay. So, Hamid, do you want to share your presentation? So,
yeah, of course. And I completely agree with Harith. Unfortunately, we had the same experience, and the two main problem was the age of the patient that were young for most of them, and some of them without any comorbidities before coming in ICU for COVID-19. And the number also of death that was very high. So it was quite a difficult time. So let me share you.
And also, I imagine that for the COVID, also the family couldn't be there to sustain those patients. So everything was on the shoulders of the nurses, the doctors, that they were doing like all the roles, the family, the doctor, everything.
Exactly. Usually our ICU is open 24 hours a day, so family can come every time they want. But during the COVID-19 pandemic, we have to close the ICU, and it was very difficult for the patient, of course, but also for us because we couldn't have this relationship with the family. So it was very difficult.
Yeah.
So let me share you my wait. Sorry.
And if you have like some questions, you have some questions in your mind, you can write it down in the chat box, and we can address to them later. Okay, great. I can see your screen.
Do you see my screen?
Yes, perfect. The floor is yours.
So thank you for the invitation. I'm honored. My name is Dr. Hamid Merdji, and I work as an intensivist in ICU in University Hospital in Strasbourg. And I will talk with you about the neurological complication of COVID-19 as my point of view. And I will do a little focus about delirium. That is a complication that was very frequent on COVID-19 patients. First of all, I do not have any conflict of interest. So this is this is a timeline of the clinical presentation and neuropathogenesis about the neurological complication of COVID-19 that were seen in hospital, but also in ICU, and I will talk about some of this complication. Even if COVID-19 is still a recent disease, we don't have so much information and evidence base concerning the way it affects the brain and the neurological system. But there are still some hypotheses that are made, and there are some putative mechanism underlying neurological consequence of COVID that explain in part the neurological complication, such as hypotension that occurs and that affect the brain, hypoxemia, micro and macrovascular thrombosis, but there were also immunological complications such as cytokine storm, adaptive autoimmunity, and microglia activation. And I will talk about this complication in the talk. So this one of the part that could explain indirectly how COVID-19 can affect the brain, but we also had evidence that COVID-19 could also affect directly the brain. And in this post-mortem study, as you can see, there were some almost 20 patients who died of COVID-19. There were some unspecific findings that were found in the post-mortem exam, such as cerebral focal necrosis in some patients, cerebral hemorrhage, cerebral edema, and spongiosis in some patients. And when the author looked at the COVID-19 directly in the brain, looking by molecular detection by RT-PCR, they found that the virus will present in almost all cases of these 20 patients. So we had indirect and direct consequences of COVID-19 on the brain. One of the question that arises is how the virus can spread into the brain. And in this review that is from 2018, so before the pandemics, it was the review was talking about the different way for respiratory virus to get into the brain. And as you can see, there are three main way for a virus to spread into the brain. One of this way is the way that is used by the human respiratory syncytial virus that spread from the lung to the central nervous system through hematogenous route. So it go in the lung and then in the blood, and from the blood it can go in the brain. Another way that can be used by a respiratory virus is the way used by influenza virus that go from the lung to the brain using the central, the vagus nerve, and this is one of the other way to spread in the brain. And the last way that is usually used by coronavirus, and it seems that this is the way that the COVID-19, the SARS-CoV-2, the way that is used by the SARS-CoV-2 to get into the brain is by getting to the brain through the olfactory bulb. So as you can see, by going to the nose, the coronavirus can enter the brain directly via the olfactory bulbs. And in some mice study, when you cut the nerve from this olfactory bulb, the mice don't, the SARS-CoV-2 don't get into the brain. So it seems that for coronavirus, this is the main entrance inside the brain. So once the virus is in the brain, how can he enter into the brain cell? In this review, they discuss this point, and as you can see, regarding the site and the area of the brain, they are more and less receptor for the SARS-CoV-2, and as you know, the main receptor for SARS-CoV-2 to enter into the cell is the ACE2 receptor. And as you can see, you can find this receptor on neuron cell, microglia, astrocyte, and oligodendrocyte. So this is how the virus can go into the brain and then into the cell of the brain. So this was just some basic physiopathology to talk about the clinical presentation that we have seen in ICU. So the most common neurological manifestation that we have seen in ICU was reported here in this study. 60% of our patients almost had smell and taste disorder, and almost 20 had myalgia and headache. Of course, that was not the main cause for patient coming to ICU, but that was the main neurological manifestation that was seen in our ICU patient. Regarding anosmia and ageusia, as you can see in this South Korean study, fortunately, after 3 weeks almost, patient had almost all patients has recovered. So it's good news. And what was the mechanism, and what is the mechanism causing COVID-19? How COVID-19 can induce anosmia? In this recent study that was on the small animal, it was hamster, they evidenced that SARS-CoV-2 was can persist in the olfactory epithelium for several months, that they infect sensory neuron and prompt immune cell recruitment that cause inflammation, and this persistent inflammation of the olfactory epithelium and of the olfactory nervous system is maybe one of the main cause of anosmia. When we look at a real patient, this time not animal, on autopsy, as you can see, the olfactory nerve in this small case series seems grossly normal, but still we lack data to know exactly how the virus can cause this neurological complication that is anosmia. Another neurological complication that was frequently present in our patient is the anxiety and depression that we have seen in a lot of our patients. And in this study, about almost 400 patients that were analyzed 1 month after COVID-19. As you can see, almost 30% of the patients who suffer from COVID-19, and one fourth of these patients weren't hospitalized, but almost 3,000 were hospitalized. And among these patients, almost 30% of the patient had PTSD and depression, while almost 40% had anxiety and insomnia. So we didn't see directly PTSD in ICU, but a lot of them had anxiety and insomnia in ICU. What about the long-term psychiatric morbidities among SARS and MERS survivor, to see if when we look at other coronavirus, we had the same complication, and it seemed that it was almost the same in the other coronavirus infection. If you look at this result from the outbreak of 2003, where of note, more than 8,000 cases were reported, and almost 800 people died during this pandemic. Almost 2 years after the coronavirus, the SARS infection, the SARS-CoV-1, almost 30%, 25% had PTSD and 13% depression. Looking at another coronavirus, that is the MERS-CoV, there was an outbreak in 2015 in South Korea, and among almost 200 patients who were infected, there were 40 deaths. And when they look at the survivor at 1 year, 40% had PTSD and 30% reported depression. So this was some complications, some neurological complications that were seen with the previous coronavirus, and it seems that it's almost the same result that we have now with the COVID-19 pandemics. Looking at one of our main complication, here's the strokes, and it was a paper from the end of 2020. The incidence was between 1% and 3%. The stroke severity was moderate, but there was a high prevalence of large vessel occlusion. And in this stroke that affect patients with COVID-19, there were not a lot of patients who had antiphospholipid, who were positive for antiphospholipid antibodies. These antibodies are known to favor blood clot in our patient, and it's a complication that is seen in a lot of COVID-19 patients who had a severe form of COVID-19. There were also a high mortality rate that was reported in this patient who developed stroke with COVID-19. Now we'll talk about an area in which we are something that affects more patients in ICU, and that we have to deal with, and this is delirium. So what is delirium? So first, just want to say that in April 2020, our team was the first to notice that, or maybe not the first to notice, but the first to publish this letter in the New England Journal of Medicine about the high rate of encephalopathy, major delirium such as agitation, confusion, and cortical spinal tract sign that we found in our ICU patient with severe COVID-19. As I already said, there are a lot of mechanisms that can explain this, but in ICU, a lot of our patient has hypoxemia. The hypertension was not so frequent in COVID-19 patient, but some of them can also develop a septic shock, and a shock state that induce hypotension. So we also had a bit of hypotension in our patient, but all of these complications were maybe maybe explain the high rate of delirium that we had in ICU, and that we'll talk about further. Even if today we don't have the exact explanation for this number of this high incidence of delirium in ICU. So what is delirium? in ICU, it's someone with a disturbance of consciousness that occurs with reduced ability to focus, sustain, and shift attention. There is a change in cognition that occurs and that was not pre-existing, and that is not also an evolving dementia. This disturbance develop over a short period, usually hours a day, and we can have and we had some patients that were completely normal and that become completely delirious in few hours, and also evidence from the history, physical examination, or laboratory finding indicate that there is a disturbance that cause a direct psychological consequence. And of course, in our patient, it was the COVID, but also the drugs that we use to make them sleep, to allow the intubation and the ventilation of this patient. And one point that is complex with this pathology, with this disease, is that there's a high tendency to fluctuate. It means that patient who had delirium can be in the morning completely normal and looks completely normal, but few hours after they are delirious, and they say things that have no sense, and once again, a few hours after they become once again normal, and this there is a high tendency to fluctuate. And one other point that is difficult, that explains the difficulty to manage this patient, is that we don't have any treatment that work on delirium, the usual delirium, but also the COVID-19 delirium. So how can we assess the delirium in ICU? As you can see here on this slide, we use a scale that is called the CAM ICU for a confusion assessment ICU. Sorry. Yeah, the confusion assessment method for the ICU, and we need to have the patient who can cooperate. And once we can ask this question to the patient, we can know if there's delirium or no delirium. There is also one other scale that is usually used, and it's the Richmond Agitation Sedation Scale. And as you can see, some of our patients can be in deep sedation, -4, for example, but also some of them can be combative or very agitated. It will be +3 or +4. And when we use these two scales, we can assess the type of delirium that our patient had, and I will talk about this point in a few slides. So I've talked about the letter about our first report in the New England Journal of Medicine about the high incidence of delirium. So when we finished this study and we published the complete study, we had 150 patients that were admitted in ICU during the first peak. And among this patient, as you can see, 140 had a complete neurological examination, and in this 140, more than 80% of patients had abnormal neurological examination, such as corticospinal tract signs or positive CAM ICU. That means that they had delirium. When we look more precisely the cause of this delirium and abnormal neurological sign, we have done a cerebrospinal fluid analysis of 25 patients only, but it was difficult in the context of pandemics to do such exam. And what we have found was that most of them, more than 70%, had abnormal CSF analysis, with with 30% of them having a high elevated interleukin-6 level, and only one with a positive SARS-CoV-2 RT-PCR in the cerebral fluid analysis. When we looked at the baseline characteristic to distinguish, to look at the difference between people who developed delirium and people who didn't develop delirium, in patients who didn't develop delirium in our ICU, there was not so much significant difference. Most of the people who developed delirium were men. And when we look, but there was no characteristic difference that induced a significant difference in the presence or absence of delirium. When we look at the consequences of the delirium, as you can see in our sample of 150 patients, it didn't change the mortality. It means that people having delirium didn't have more mortality than people who did not develop delirium, but the length of stay was much higher, and there was a significant difference, as you can see here, regarding the length of stay in ICU. And people who developed delirium had a length of stay that was more important. These are the delirium common risk factor, and as you can see, they are predisposing factor and precipitating factor. And regarding our COVID-19, as I told you, except the sex, none of these factors were found to be significant when we look at our patient. But these are the common risk factor for delirium in other causes than COVID-19. Usually, you can have two main type of delirium. These two subtypes are the hypoactive delirium and the hyperactive delirium. And in this study that looked at almost 600 patients, in ICU, almost 80% of the patient older than 65 had delirium in ICU. So as you can see, it's always pretty high, and it was before COVID-19. But to remember, in our COVID-19 patient, we were higher than this percentage of almost 70%. And as you can see, most of the patient will develop an hypoactive form of delirium. And this hypoactive form of delirium is sometimes difficult to assess, because when you have an agitated patient with hyperactive delirium, it's very easy to assess and to identify. But when you have hypoactive delirium, it's sometimes difficult to identify. And usually this is how we represent the delirium in ICU, saying that maybe what we see is not the more important. And sometimes even with the CAM-ICU scale and the Richmond scale, it's difficult to assess the hypoactive delirium. This delirium is not without consequences, because as you can see, when you have delirium, and it can be hypoactive or hyperactive delirium, the risk of dying for this patient is higher than people in ICU who don't have delirium. So delirium is a main problem in ICU, and as I said before, we don't have effective treatment. We have some treatment that may help, but nothing that is specific for this kind of problem. Other neurological complication that we have seen in some of our patients was the Guillain-Barré syndrome and its variant, and some report showed that the Guillain-Barré syndrome and one of these variants, that is the Miller-Fisher syndrome, can happen after COVID-19 infection, but we lack data today to say if this pandemic with SARS-CoV-2 induce more Guillain-Barré syndrome than other type of infection. But after 1 year and a half, it seems that it's almost the same. But I don't have the last data about this point. And one of our main neurological complication that we had in ICU was the ICU acquired weakness. And the way people develop ICU acquired weakness is because that when you have COVID-19, you don't eat, you have higher catabolism, you have a cytokine storm, you don't move, you have muscle wasting, low albumin, immobilization, and all of this induce cachexia and long-term sarcopenia. And when you look at ICU acquired weakness, and we talk we talk of ICU acquired weakness when we have an MRSA score that is higher than 48. As you can see, at the awakening of our patient in ICU, almost 70%, 70% of the patient had no ICU acquired weakness, but almost 15% had, 50% of our patient had this ICU acquired weakness, and this ICU acquired weakness was going down lower at ICU discharge and as at hospital discharge. But this was another complication because patient with ICU acquired weakness cannot move, and it's very difficult for them to move, difficult for them to sit. So it increased the length of stay in ICU, and make the less places available for patients with severe ICU. When we look at the consequences of the ICU acquired weakness on this 80 patient that I talked just before, there was a prolonged ventilation, more frequently this patient more frequently receive dialysis, and maybe one of the explanation for this ICU acquired weakness that was more important in COVID-19 patient was because the exposure to corticosteroid was important, and we know that this can induce muscle loss. They had high dose of sedative and analgesic, and also non-muscular blocking agent that also can cause ICU acquired weakness. When we usually look at the complication in terms of functionality in our patient after an RRDS for acute respiratory distress syndrome, and that was the main cause of admission of our COVID-19 patient in ICU. One of the main point that explain the decline of the physical status is the age, and we don't have data yet for the COVID-19, but when we see the high incidence of ICU acquired weakness, maybe the age also will be one of the main characteristics that will explain the decline, the functional decline in this patient. So this was I spoke about the neurological complications that were described, but of course there are some hypotheses about other neurological complications that also can arise from these pandemics. And one of the editor that I read and that was interesting talk about the possibility that COVID-19 can lead to a cognitive decline because of the cytokine storm and the hypoxia and all of the physiopathology that I've talked just before. And when we look at other study concerning people who had the same pulmonary disease such as the COVID-19, and I'm talking about the RDS, acute respiratory distress syndrome, that I just spoke before. As you can see, even 2 years after hospital discharge, this patient had still consequences and sequelae of their RDS, such as general memory index that was lower, attention and concentration that was lower, and also a memory problem. So maybe we will see the same problem in our COVID-19 patient that were in ICU in the future. One of the other hypotheses is about the potential increased risk of developing Alzheimer's disease, but I don't have more data about this. And in one editor also, I found that this COVID-19 could maybe accelerate the pathogenesis of patients' brain disease. I absolutely have no data on this, and it was just an editor. But I just wanted to talk about to do an overview about the neurological complication that could may potentially touch the COVID-19 patient. So today we lack clinical studies but also experimental studies about COVID-19 and how it affects the brain and the neurological system. But as you can see, there are a lot of clinical studies that are register and that are ongoing, and maybe in the next month or the next year we will have more information about how COVID-19 affect the brain and all of this neurological complication, if they will do persistent and long-term complication in our ICU patient with COVID-19. Thank you for your attention.
Thank you, Hamid. This was really a comprehensive talk. I had a list of all the neurological things that connections I could think about the COVID, and you addressed it all, and also even more. And so if anyone has some questions, please feel free to ask. Okay, Stephanie. Okay, you can go. I think that, okay, Alessandro. Okay.
Thank you for the wonderful talk. I actually have a question for both of you, because both of you briefly touched on it, and that is the long-term consequences of the neurological complications with COVID. And in one of the last slides, you just showed that even after 2 years, there might be a memory and attention deficit in those patients related to the infection. And I was wondering if you actually get to follow up the patients that you now treated in the acute stages.
No. As an ICU doctor, I just see the patient in the acute phase, and we are studying some, actually my area of expertise is not the neuroscience or neurology, but and so we don't follow this patient, but for some patient, I work on cardiovascular long-term complication, and we follow some patient, and this kind of patient that had heart attack or this kind of complication in my ICU, because we focus specifically on this patient. But no, I don't follow patient, and especially I don't look at the neurological long-term complication.
Harith,
I think it's difficult. Obviously, this is it might take years for us to understand if there is an effect. I think we have to look at, there is an advantage in having big numbers, because even if the effect is small, they're quite it's a very big number of people who were affected by COVID-19, and it might actually end up helping us understand other conditions. For example, there's, I don't know if you know of something called chronic fatigue syndrome, where, it's one of those conditions that's very poorly understood. And it's possible that it's a post-viral encephalopathy type of pathology. Because the numbers are small and the patients tend to be alienated as well, it's very difficult to get pattern. Because we have a lot of patients, and we know with COVID, for example, some patients get long COVID, and they have similar presentation to patients with chronic fatigue syndrome, where they're tired and they've got myalgia, and so we might learn more about the brain following viral infections. We just have to. The good thing is we have those registries, we have those big international cohorts and this collaboration, and actually COVID sort of helped with getting people together over Zoom like we are now, in a way that we perhaps wouldn't do before. So a lot of people are working together with putting patients together to follow this up. If there is a pattern, it will emerge with time. As I said, we have big numbers, but it might take quite a while. We don't know, how long.
Thank you.
Yes, definitely. I think that acquiring data is a key feature here to understand. So Alessandro Villa, please go on.
Yes, I catch up a bit on the question made by Stephanie. I think it's very important to have these follow-up studies. And usually one of the weakest point I would say in those studies, it is that the people who see the patients in the acute state, like both of you, because you see the patients at ICU in a very delicate state, and then the people who follow up the cognitive impairments months or even years, ages after the intervention. So I think it's very important that you can immediately start to seek for collaborations now, because you have an absolutely very, very fundamental role to play in describing the patients when they arrived. Otherwise, this is a little bit lost. As you know, retrospective studies made on the previous pandemics in the Asian influenza pandemic or even in the Spanish, there are very few descriptions that can help in this context. And then I also have a question about these major long COVID symptoms, because you have basically the two types. You have the movement disorders and the cognitive impairments. And you probably know that there are already some studies that have been associating the amyloid PET and the tau PET with the COVID-19 patients. Do you have any of those evidence, or do you have any tau PET or amyloid PET done in your hospitals? No,
I don't have this data. Sorry.
Yeah.
No, I know that there are some hospitals that start to show evidence of the association between amyloid PET and tau PET. And,
but I suspect, because these are these proteins that you'll find post-mortem, and it wouldn't be in patients who died from COVID, so they will have had to survive and live for a few years. So I don't think we're there yet. We know that tau protein, even when it starts, takes quite a long time to infect other cells, which is what we think, how it works. So I think it's early on, but we shouldn't forget that the general population also has a risk of developing Alzheimer's and Parkinson's disease. So we need to distinguish whether this is just coincidental, or basically one of the main questions in any scientific experiment, whether it's an association or a causation.
Yes, I completely agree. I think this is why it is very important that now when the patients come to your ICU, then you might establish some randomization or some protocol to select those patients that will be followed up in order to avoid some bias, because absolutely, you are perfectly right. There is a big risk of having a bias in the follow-up cohort of patients.
We don't follow as intensivist this patient, but our colleague do, and neurologist, pulmonologist, and cardiologist also look at this patient closely. So we will have this data, and but I think that for us, it's a bit difficult because once again, it's not our area of expertise. So it's not what we do usually, but I'm sure that our colleague will do it very well.
Yeah, I mean, we have in the UK, we have a long COVID service. So there are specialist clinics at UCLH for patients with long COVID. And we also have MDTs for patients with neurological, so it's COVID-related encephalitis and encephalopathy. So these patients are being followed up. We obviously can't follow up everybody because it's hundreds of thousands of patients. But yeah, the patients who develop neurological, central nervous system related or long COVID get followed up. So we'll have to wait and see.
Yeah, probably COVID will be like a coverage in the future publications if you like it or not. Yeah. So, Cyrine, do you have a question? Feel free to ask it.
Yes, thank you so much for all these presentations. My question would be about the effect of COVID on cognitive functions. Is it necessary and is it possible as well to measure objectively this decline in cognitive functions caused by any of the effects of COVID? Because we don't have a basis measure, for example, and then people report. And is it necessary to really objectively measure these effects in general or not? And is it possible?
Harith?
I think we definitely should measure them, but again, we just have to be careful because cognitive function can be affected by lots of things. The main thing is these are patients who are seriously ill, so any kind of serious illness can affect your cognitive function. If you're on ITU on being sedated for months, that will affect your cognitive function. If you have depression, after getting COVID, will affect your cognitive function. So it's not something that can be easily ascertained, I guess, especially if you've had severe form of the disease. I guess it might be something useful if you haven't had serious disease, but you've had kind of long COVID without respiratory complications, without needing to go to ITU and needing intensive care. That might be interesting to see. But I'm sure that there is some form of cognitive decline with getting a serious illness, and in the acute phase, it's not very useful, I suspect. And if you have a proven central nervous system injury from the infection, then you would I'm sure you get some form of cognitive dysfunction depending on which system in the brain, which circuit in the brain is affected.
Yeah, I agree. Stephanie, last question in the interest of time.
Thank you. So you nicely showed the different pathways of how a virus can enter the brain. And I was wondering if you could also comment about the brain-blood barrier, which usually should shield the brain from intrusions that damage it. So how does the virus actually manage to bypass that security system of the brain?
Should I get that? Or Hamid, did you want to?
Either.
I have I can answer because I don't I don't have the answer. So I will let Harith respond if you had.
So I'll get that. So I mean, the routes of entry, there's always some local inflammation first. So your blood-brain, and by the way, you don't have blood-brain barrier everywhere, and that's one thing. The other thing is it's direct infection to the brain. So you're not going through the blood. It's not a blood-borne infection. So blood-brain barrier is not really relevant here. But the routes of entry are usually inflamed first, the olfactory bulb, and that gives you direct entry to the brain, or the nasopharynx and the vagus nerve. And that the vagus nerve is interesting because that's obviously that takes that gives. It will take innovation from your entire GI system. I'll give you an example. This is from big population studies. So back in the day, when I was still in medical school, we did a lot of work and studied a lot about an operation called vagotomy, which can be a selective vagotomy or radical complete vagotomy, where we used to cut the vagus nerve because that was one of the treatments of peptic ulcer disease, which was very prevalent until we discovered that peptic ulcer disease is caused by a bacteria called Helicobacter pylori, and that you can treat it with taking 3 antibiotics, and all these operations that we used to do disappeared. But the patients who had vagal nerve section had much lower risk of developing Parkinson's disease than patients who didn't have vagus nerve section. And that was an indication that there is something here, that there's this pathway, this kind of highway from the gastrointestinal system to your brain was potentially carrying something that is causing Parkinson's disease. So it's an interesting idea. We found this after years and years and years of doing this operation, so it's not something that happened straight away.
Yes, I think it's super interesting also this frontal, the gut brain and all the connection. Yeah, it's really interesting. So aware of the time, we can continue the discussion later on, but for the ones who would like to leave, I just say I thank you the speakers for their amazing talks. They were really great and really great insights in what is happening now. I really thank you. Then I would like to remind you that the next talk is going to be on the 27th of January, the first of the 2022, by Harith Akram about brain behavior evolution in domestic dogs and foxes. And I also remind you our weekly journal club on Monday. I also share in the chat box a machine about the delirium. Nature revision, because yes, I also thought it was really interesting for the ICU care. And again, thank you for joining us today. And if for the ones who want to continue the discussion, feel free to stay connected. Thank you.
Thank you. Bye.
Thank you very much. Thank you.
Bye.
Now, for those of you who are still here, did you had any questions?
Actually, you answered to a lot of my questions. Yes, like the most like the thing, it's like if what is more connected to the pathogenesis of the virus, or like a side effect of all the stress triggered by the COVID infection? I think that this was my main question.